Okay, the next session is going to be tumor boards in focal therapy. Can I invite Sanjit up, moderator? Yep. Okay, can I invite for the first session, anterior tumors? Can I invite all the speakers to come up, please? This is going to be because it's 4 o'clock and everyone's tired, so it's going to be a rapid fire session. Everyone's only going to talk for 3 minutes. I gave them 3 minutes. So we're going to show, it's going to be quite exciting. So for anterior tumors, we're going to show hey, have a seat, Sanjit. We're going to show how we treat with cryo, HIFU, IRE, or whatever modality, and then you guys are going to decide, see what you think. What do you think is best? How are you going to do it? So these are all experts that are going to show us how it's done. Sanjit and I will moderate. So it's a little bit like a chit-chat. Please participate as well. The first segment is anterior tumors, second segment is posterior tumors, and the last one will be peri-retro tumors, so 20 minutes each. Without further ado, I think we're going to start with Dr. Amir Labasi. He's going to show us how he would treat an anterior tumor with HIFU.
All right.
Amir, please.
Yep, thank you very much. I'm trying to make it brief, not other people. Focus there for anterior tumors. So I have a couple disclosures. What energy modality? That's always the question. And I in general say for transrectal, or for posterior tumors, I like to use the transrectal approach. It's right there. I like to cook, the tumor right with the probe transrectally. It has the shortest energy source to tumor distance. For anterior tumors, I like to avoid rectal and urethral injury by bypassing them. I like to use a transperineal approach. Again, the shortest energy source to tumor distance. Now, so I divide the prostate when I talk with my patients into the northern hemisphere and southern hemisphere, and posterior tumors in general, I say probably preferable HIFU, anterior tumors, cryo and IRE. But I'm going to tell you that in select cases, I do like to use HIFU also for anterior tumors. And why is that? Because I can reach with the HIFU machine the lateral aspects and the anterior aspect of the prostate as well. As long as it's within 4 centimeters with a focal one machine, you can reach everything in the prostate. So basically, adjust the system to your needs so you can treat anterior tumors. And sometimes it's also useful. And why? This is the workflow for all my focal therapy cases. I get the MRI, then perform a systematic and targeted biopsy. Then I like to get a PSMA PET scan and a confirmatory biopsy for all patients, and then perform focal therapy. But each of these steps, I can find reasons why I like to use a HIFU transrectally. With the MRI, there might be concomitant MRI lesions in the posterior aspect. And if I want to treat the entire hemisphere, why not heating everything up from the rectum and cover also all the satellite lesions that are posterior? Or if I perform my biopsies, maybe the target had a Gleason 7 disease, but there was also positive course in my systematic course. So I would treat everything if I come from the rectum and bring the energy up. Or on the other hand, what if I get the PSMA PET scan or perform a saturation biopsy and the PSMA PET scan actually unmasks that the disease burden is actually more than just in the anterior aspect. So here, preoperative MRI, the patient, another patient, he had an anterior tumor, but he also has a PIRATS 3, red as far as PIRATS 5, yellow is PIRATS 3. There was a concomitant lesion in the posterior peripheral zone, so I preferred HIFU in this setting. Or in this case, the patient had a systematic biopsy. The systematic biopsy showed, again, in the peripheral zone tumor, so why not treating everything from the rectum? We all know the risk with cryo and IRE have in the rectum. I know you guys are all going to say no, but I know it has. So for posterior tumors. And on the other hand, what if I get a PSMA PET scan, and the PSMA PET scan actually shows that there's bigger disease burden. So the tumor, I see it lights up all the way to the rectum. So in those cases, cryo, IRE, which I usually prefer for anterior tumors, are not preferable. So this is actually, the patient from me last week had an anterior tumor, but also the systematic biopsy had also posterior some tumors. You see the Foley catheter is is still in. On Tuesday, before I came, I did a transrectal ultrasound 7 days later. I can guarantee you that his systematic biopsy course in the peripheral zone, as well as the anterior tumor, are dead, as the image shows. So in conclusion, treat the individual patient. And I think HIFU should be considered for anterior tumors if there's concern for concomitant disease in the posterior prostate, meaning based on the preoperative MRI, biopsy results, PSMA PET scan, or my confirmatory saturation prostate biopsy showed some disease in the posterior peripheral. You guys know cryo IRE are very bad for those. Thank you.
Thanks, Amir. All right, thank you so much. Next speaker, Dr. Tan Wei Pin, will show us how to treat the anterior tumor with cryotherapy. Wei Pin, please. I'm putting you guys on a timer, by the way.
I need my slides then. There's a timer going. Okay, I want to point out a few things. So Amir said a lot of what if. This is not what if, okay? Jack gave us a case, okay? It's a guy, PSA 6.7, anterior. This is his MRI, see? Obvious MRI lesion anteriorly. Amir was a lot of what if, no. So he even gave us a biopsy. He showed us where the cancer was, and you can see, this is the image that he actually gave us. You know, he had 1 core of 4 plus 3, 3 cores of 3 plus 4. Essentially, this is how it looks on Amir's little image that he put up, right? So how would I do this? First of all, you know, as what we do at NYU, we would kind of mark out a margin, 1 centimeter margin around the area of concern. You see the MRI lesion, you see the biopsy. And usually what we do is with an anterior lesion, you can actually go to town. You know, cryoablation is easily the best energy modality for it. You can just crank it up, go to minus 120, everything dies above minus 40. Essentially, you know, I'll lay out my probes, you put in your urethral warming catheter. At NYU, what we actually do that's interesting is we actually put temperature probes into the margin. So essentially, we'll put our temperature probe dead in the heart of the lesion. We also put temperature probes around the 1 centimeter margin of the tumor, just to get, you know, a good, accurate measurement that we actually freeze what we wanted to, and we freeze the margin to it. And then to that, you freeze, right? So usually when you do cryoablation, what happens is you have a kill zone and you have a freezing zone, because essentially, you know, tissue usually would freeze at probably -2 or -3 or so. The freezing point of water is -0 degrees Celsius, but tissue usually needs a little bit more. So you get, when you look at the ultrasound probe, you see ice. It doesn't mean that's the kill zone. So you got to make sure we map out the kill zone. And in, you know, in that lesion that Jack gave us, easy. After this, everything is there. I had a case like this myself, you know, slightly higher PSA, Pirates 4 lesion, biopsy showed 3 plus 4, PSMA was negative. Because his PSA was above 10, we got a PSMA PET, intermediate unfavorable risk. You know, essentially freeze that. 6 months later, the MRI is in, nothing is there. Nothing survives, minus 40 degrees Celsius. So, did you delete my slide?
Fantastic.
No.
Pin, I was gonna
Time
say-
is up. Thank you.
Seconds left, but you're fantastic.
Very weak points. Thank you. Next one.
There was a slide
point.
that's missing, but essentially, you know, if you look at Newton's law, you know, 1
Time is
over
up.
radius square, right? We know the further you are from
Time
the
is up.
energy source, the less energy is going to get to that area. Why would you treat something that's anterior, 4 centimeters away from the rectum, when you have other energy modalities?
Great. Thank you.
So now you know who deleted your slides, Pin. All right. Thanks so much, Pin. Yeah, a nice case. You get extra points for showing the case that I gave.
Yeah,
So
great.
next we have the esteemed Professor Phil Stricker from Australia, world expert at IRE. He's going to show us how to do anterior IRE. Thanks, Phil.
So I have exactly 3 minutes. I'm told that I go over time.
Yes.
For an anterior IRE case, Jack gave us a nice easy one. So I thought maybe we'd give you just a slightly harder one with a slightly bigger prostate, PSA's 8.8. And here you've got an anterior lesion. And the biopsies are shown here to be Gleason 3 plus 4 anteriorly, not only at the anterior, but at the base, and the PSMA PET scan is positive. So 5 electrodes were used to get rid of that. This is the initial 2-day MRI, which shows patchy hemorrhage, and this is the scar tissue that occurs afterwards. And this is the biopsy showing the green circles are clear, but showing nanoknife effect. PSA is down, and this is the post MRI on that one at 2 years, and this is just a video showing exactly how we do it. And so if you look here, this is the needle placement, and this is a very large prostate, different case, but it's a hard anterior case. Now the bones got in the way at that point, so all we just do is just move the probe a little bit to the right, and to make sure that we can get up there. So this would be challenging with HIFU with about an 80 to 90 gram prostate. And so yet, having done that, we've just changed the probe and we've got the needle exactly into the right place here, the needle in the right place here, and the needle in the right place over here. And then we just have to put one more here, and then we do a longitudinal scan just to make sure that we can see that the tumour is covered in the Z-axis, to make sure, and we've got a good safety margin. One of the beauties of IRE is that we have about a 2 centimetre safety margin in every case, and we measure from the apex, and then we make sure that we've got good parameters on the Z-axis. We make sure all the electrodes are parallel at the time, and during the actual treatment, you'll see that this area which we're treating here starts to go white as a feedback, which is one of the nice things about IRE. You can see the electrodes pointing upwards. That's not an issue. You can get any size prostate anteriorly, and with any safety margin. The electrical parameters are there. You do have a little bit of movement, and you need to be careful that the electrodes don't move. You can see the hyperechoic area here, which is occurring, so you get some feedback. You can check that in the longitudinal axis as well. And so ultimately, it's a fairly simple 45-minute procedure, and you can treat not only that area, but if you do have some coexistent lesions posteriorly, you can go posteriorly.
Thanks, Phil. Nice case, really nice. We're gonna ask you more about paralysis later on, but next we're gonna have Dr. Arnold Villers. So prostatectomists in the audience, don't despair. Dr. Villers is gonna show us how he does anterior robotic prostatectomy.
Okay, so we know that this location is a challenging location, and I know that, you know, when you see that lesion at MRI, the extent actually of the tumor is from bladder neck to apex. So how can we remove all this area? So this is the way I do this simple radical prostatectomy, and in addition, I remove the anterior fibromuscular stroma with large, margins to be sure that I removed all the cancerous area. And then I just finished the operation pulling the opening of the bladder neck to the anterior distal urethra and membranous urethra to have a watertight anastomosis. So leaving only the peripheral zone without these anterior horns at the apex, and hoping that I removed all the cancer. This is a typical case I would select for this operation, and you need that these sagittal views are important for assessing the tumor extent. And so you can see the pathology and the specimen with the tumor removed. So I have a series of 28 cases followed for 7 years, and very good functional results, as one should expect as in simple prostatectomy procedure, and long-term outcomes at 7 years. I would say that I had to do salvage in 8 of my 28 patients. And when I went back to the selection criteria, I thought that patients with more than 3 cc of cancer at MRI were not good candidates, and they have some residual cancer at the bladder neck. So this is the only place where I may have left some cancers. So I did completed radical prostatectomy. It's reversible to this operation, and patients are doing well. So that could be an alternative to this anterior cancer case. Thank you very much.
Thanks so much, Arnold. All right, so I think this is good. We have some time for some comments and discussion. Anybody wants to ask any questions?
So I have two questions. One is for Amir and the other one is for Arnold. For Amir, I want to ask if there's a recurrence anteriorly, will you switch your strategy in terms of the energy modality? And how are you going to tell your patient if you are going to switch energy modality?
Yes, if there's recurrence, which rarely happens, I would treat it differently.
Cryo.
Cryo or IRE, they're equally good.
Okay, for Dr. Arnold, I wanted to ask if for the 8 patients that had recurrence, if you ever had to do a prostatectomy on them, is it going to be technically a lot more challenging?
Yes, I would say yes, because I went once at the apex, not the posterior part of the apex, but the anterior one, and oncologically speaking, patients are doing well, and I removed all the cancer, but then the continence was the less good that it would have been if I would have done a radical immediately.
So would you do like a focal for them if they were to recur posteriorly?
A focal?
Like you HIFU?
Yeah, no, I won't. I will do IRE.
I had a quick question for Amir, actually. Transrectal HIFU for anterior tumors.
Yes.
Do you worry about calcification? Do you use ultrasound to assess if there is calcification?
Yes, rarely the case. Maybe, I don't know, but there are 2 cases overall that I couldn't do if there were calcifications, but rarely the case, yeah. When we do our biopsies, we always scan a panorama scan of the prostate. We know if they have calcification or not, yeah.
I'd just like to congratulate Arno Villiers for that paper. I mean, to get histopathology of the anterior tumours and to give us guidance as to which tumours should not be given focal therapy, i.e. anything above 2 centimetres or so, or certainly 3 centimetres, is fantastic information. But the other thing is, you've shown us that they're much more extensive than we think they are. And so for anybody doing focal therapy of an anterior tumour, you have to treat way wider than I used to think when I first started the program. And so I think that's a lesson for all of us.
Just a quick one, Phil. If the anterior tumor is kind of like abutting the margin, abutting the capsule, do you feel that you can drive that? How far do you feel you can drive the IRE out of that capsule safely? And where do you put that most anterior needle?
So this is one of the great advantages of IRE. If you put the needle 5 millimetres from the edge, you get treatment to the edge of the capsule. But if you keep it 3 millimetres from the edge, you actually treat extracapsular. And I've had the opportunity to do radical prostatectomies in 32 patients on these patients. And whilst there's been no recurrence in that area, the fibrosis periprostatic in that area is quite intense. So you're clearly treating extracapsular disease in that area. So I have no hesitation in putting the needles much closer to the capsule.
Can I ask a question? Because I think that's one of the advantages, and I love the modality. But isn't there the concern if we go too close to the urethra that we also treat the urethra?
So the urethra is a different story to the anterior capsule. So with the urethra, you have to keep the needles 3 millimetres away from the urethra because of the heat effect, not because of the IRE effect. The IRE won't cause a stricture, whereas with other thermal modalities, it will cause a stricture. But it does generate heat within 3 millimetres of the needle. So you have to keep the needles 3 millimetres either side. You put the urethra in the middle of it, it'll be edematous, but it will not stricture.
Right, thanks so much. So I think we'll move on to the next segment. I think everybody stays in play because you guys can have comments and stuff like that. I'd like to invite the posterior tumor people to come up. Phil is staying here, Kian Tai Chong, Samuel Yee, and Chelly Verrall. So while they're coming up, let me just poll the audience. You or your loved one has an anterior tumor. So who would get cryo? Who would get IRE? Who would get HIFU? Who would get an anterior prostatectomy? All right, guys, well done. Thanks. Okay, so let's have our next speaker now. For HIFU posterior tumors, Dr. Chong Kian Tai from Singapore, who has pioneered HIFU in Singapore in his private center. Yeah, please take it away.
Thank you very much. We are sharing our early experience, and we only do HIFU using the Focal One machine for the last 5 years with a short early experience.
3 minutes.
So my topic is going to talk about how to locate the MRI lesions first using the Pirates lesion to see whether the biopsy itself shows positive cancer or no cancer within. After that, you have to decide your HIFU strategy and decide whether you have to target only the single lesion, multiple lesions, or do you have any tumors outside the target. These cases are all my patients. So the first one is Mr. 54-year-old gentleman with PSA of 5.34, small prostate with a left mid 1 centimeter Pirates 4 lesion. As you can see, for this I use a Coelis transperineal biopsy. You have to decide whether to biopsy around the lesion as well to get a good margin for treatment protocol. So you have to decide after biopsy whether the cancer is only within the lesion, are there other lesions outside the target, and also whether they are contralateral tumors. For this particular patient, we had a biopsy, shows a region of interest with a Gleason 4+3, grade group 3 tumor. The left prostate peri-lesional area also have cancer, but grade group 2. And PET scan shows no mets, so clinical T2B. So for this particular patient, because he has peri-lesional lesions, I opted for a hemi-gland treatment protocol. This is a standard operating theater setup for a patient facing the right side. And when we first start doing it, you must make sure the probe itself has no air bubble, because the ultrasound effects will be lessened if you have air bubbles within the treatment protocol. And this is a treatment arm that you can see on a computer. We decide to do a right or a left hemi ablation protocol. The computer would tell you exactly where you are going to treat. And if you look on the bottom right-hand corner, the key thing is you must stay away from the apex with the protection of the pelvic floor muscles, at least 5 millimeters away from the apex of treatment.
1 minute.
For the treatment itself, these are the rectal temperature probe, and especially for posterior tumor, there's a temperature marker between the 6 o'clock of the prostate with the rectum, and this is a live treatment. The green dots shows you the area is going to treat, and with a 1.7 millimeters accuracy, and the red dot shows the treatment that has been done. And on the treatment progress, you will actually see the red color showing treatment has been done, green is on the way. And the patient, at the moment, we do day surgery, patient goes home on the same day, and most patients go to restaurant with their wife the next day in Singapore. So there are special cases for posterior tumors. You have to look for patients with other surgeries previously, including pelvic radiotherapy or surgery, and also the prostate anatomy. Some of the patients may have large prostate or huge intravesical prostatic protrusion, and these are some of my cases. For example, the first patient, 55-year-old gentleman with laparoscopic low anterior resection with scars because he had a moderately differentiated rectal cancer. His PSA is 4.3 with a Pirates 4 lesion, and you can see it very clearly abutting against the rectal wall. The biopsy was done using Urofair transrectal system, and his ROI, the lesion shows a grade group 2, and peri-lesional also grade group 2. So we decided on a left hemi-gland treatment on the left-hand side.
We're going to have to wrap you up soon. Do you want to show us any last image
Sure.
of this case?
The other patient, just want to show, in case you find patients with a large prostate with intravesical protrusion, and then the cancer is on the posterior side, you can choose to do TURP first, followed by HIFU, and this is a series of MRI scans you can follow up to make sure there's a regression of the treatment site with a good PSA and good treatment outcome.
Thank you very much.
Thank you very much.
Thank you. We will save the rest for the discussion. Very good points. I think the next one, let's have Samuel Yee show us how to do posterior tumor cryotherapy.
Thank you, Jack.
Samuel, take it away, please.
Right. So can I have my slides? Excuse me?
We'll start a timer when your slides come
Well,
up.
thank you. Well, I just want to use a case to illustrate how cryotherapy can give you some flexibility in managing both anterior and posterior tumors, because sometimes you may not have a choice of more than one energy. Now, this is a patient actually on PSMA scan, he was found to have 2 lesions. I'm being honest, I didn't make up the ASAP, so it's really an ASAP lesion. So he has a big anterior lesion as well as a posterior lesion in the apical area. So when we look at the distance of the anterior lesion, actually it's more than 4 centimeters of the rectum. So it's a bit difficult for us to use HIFU. And we want to manage the patient in one go. And in that setting, we try to use cryotherapy to manage this at the same time the anterior lesion as well as the posterior lesion. And we use the hydrogel as the spacer between the rectum and the prostate. We begin the procedure first with the injection of the hydrogel because the lesion, especially the posterior lesion, is on the left side of the prostate. So we focus the hydrogel injection more towards the left lobe so that we can lift up the prostate a bit more. So it is a bit different from what we would usually do when we're injecting hydrogel for general irradiation cases. We would make a more even distribution of the hydrogel. So as you can see under ultrasound guidance, there's injection of the hydrogel just below the lesion that we would like to ablate. It gives us a very good distance between the prostate and the rectum so that we can have a better safety margin when we try to expand the the ice ball boundary beyond the prostate. And after that, we'll just do the ordinary planning for the cryotherapy. Here we use, again, the Coeus navigation system. We even map out the location of the hydrogel, as can be shown here. And this are the locations of the 2 lesions. And we'll have a simulation of the cryoprobe and trying to cover both lesions almost like a reverse hockey stick manner. Here we have also put in a temperature probe inside the hydrogel in order to demonstrate the temperature change. You can see the ice ball is expanding. It's almost touching the temp probe. And here you can see that with the temperature drop, it's still way above the 0 degree. So the rectum is being protected quite well throughout the procedure during the whole cycle. Even the ice ball seems to be even approaching the temp probe. So the thermal insulation of hydrogel is proving its usefulness as well. This is the post-op 1-week MRI. We show that the ablation zone is being well covered. And this is, again, the post-op 6 months and 12 months MRI. You see the hydrogel on the 6 months is still over there. It's not yet absorbed. So the patient go home in 1 week with a drop to less than 0.57 PSA. Thank you.
Thanks so much, Samuel. Really nice work. Nice application of gel. Next one, Professor Phil Stricker again, posterior tumor IRE. He's going to show us how to do it.
First of all, could I just thank the organising committee for having me here. This is my last presentation. I'll be on a plane in 2 hours. So thank you. This is a posterior tumour. Could I have my slides, please? And so this is a typical posterior tumours. 2/3 of my 500 primary cases were posterior tumours. And this is a fairly typical guy, 61, Gleason 3+4, right posterior medial, PSA 2.5 up front. Targeted biopsy was 3+4, the rest were clear. This was the MRI on day 2. As you can see, some edema and hemorrhage there. We've had no rectal areas problem. One of my colleagues injects water into the space of the hydrogel if they want to, because it doesn't conduct electricity. This is the 6 months MRI, which shows scar tissue but no perfusion, and you can see the PSAs have come down nicely up to the current time. And the biopsies, everybody gets a biopsy, the biopsies are clear. So if we look at the position here, this is a posterior tumour. It's on the right-hand side. I've picked a hard case where there's bony interference with... I apologise for the video. There's bony interference, but despite the bony interference, again, we just make sure that the ultrasound probe, again, is placed to the right side. It makes no difference where you place that. These are the electrodes going in, and this is the right posterolateral region. 1 electrode, 2 electrodes. Now that electrode's 3 millimetres from the edge, so that edge there will actually treat a bit of extracapsular at that point, and there's been no issue with regard to rectum. So this is a very simple 4 electrode treatment. Again, you can look in the longitudinal plane to see exactly where the area of treatment is. And again, you double check the distances, the z-axis, to make absolutely sure you're doing a regionectomy. And as you're treating, we always keep this very simple plan on the screen to make sure that we've got all the numbers there. And then while we're doing it, and we can see the electrical parameters, has to be greater than 15 amps while we're doing it. And then we just wait until, is that stopped? Okay, I'm not quite sure what happened then. But basically, it goes white, the area gets nice feedback, and the results in 500 cases have been published in the British Journal, and 244 of them with about an 85% 5-year biochemical, failure-free survival. So we're very happy with the posterior. In fact, we're happy with the anterior as well. Thank you.
Fantastic. Thanks so much, Phil. Thank you very much. And we're going to ask you some more about that. But before that, we'll have the last speaker for this segment, Dr. Charlie Verrall, posterior tumors laser ablation.
I've got a 3-minute video. I've timed this. Go for it. Thanks. So, as I said in my previous presentation, the focal therapy is quite simple. All you need is an ultrasound and a stepper. We have changed from a grid to freehand. It makes the treatment quite easier in the X, Y, and Z axis as well. Once you know that you are on the right or left-hand side, the laser introducer is inserted under vision. At this point in time, all you want to be able to do is ensure that you're a certain amount of distance away from the edge of the prostate. That's all you need to know. You can be between 3 to 7 millimeters, and then you basically just dial up or dial down your laser energy. And if you want to push in or pull back, depending on how you are and where you are, is pretty much where you extend your ablation zone to. So that's pretty much, you can see it on the axial axis as well. I've got 2 cases to present, very straightforward, common cases of a middle-aged gentleman, PSA 14, small prostates. The small prostates are as difficult as the very large prostates because there's not much to play with. You can see he's got a Peyronie's lesion on the right-hand side, biopsy proven. And what this gentleman, from a planning point of view, we just want to know the extent of the tumour and how and where we want to treat from. Usually we go from medial to lateral. And there are 2 or 3 parameters that you just have to know when you do the treatment. One is the distance away from the edge of the prostate, so you know you're going to extend all the way to the capsule, and to make it a confluent area, post-MRI, about 1 week post-MRI, this is the ablation zone you get. And you get a hyperemic capsule, which is quite common following focal laser therapy. And this is in a coronal section. You want to make sure that you're ablating all the way through to the apex. So you can do a push-in or a pullback. And you place the needles sideways as well. Each ablation will take between 2 to 3 minutes. So when we do these treatments, it's quite simple because all we need is the profocal system and a laser. Very simple, very similar to a TP biopsy. So it's a slightly more complex case. So the patient has 2 lesions on both sides, more elderly gentleman. Again, a small prostate, so these aren't the easiest ones to do. So you plan the base area, so you have a bit of an idea where you want to be. Because one's towards the base and one's towards the apex, all you need to do is basically just arrange the craniocaudal placement of the needle. And you can extend your treatment from left to right, basically. And again, 1 week post-treatment. On the left-hand side, the apex lesion has been taken through a bit further. And I should thank Henry Wein, our resident registrar to be for these videos. So thanks very much, Henry. It's 3 minutes.
All right, great. Thanks so much, Shelley. Very, very nice video. There was a nice cavity there. Any comments?
Perhaps for laser, have you ever used hydrodissection? Did you ever have to use spacer or hydrodissection for posterior tumors, especially the ones which are sitting right on the rectum?
Interesting. When we first started, we thought we should, but we never have, and we never needed to do so because you can control where we're going. Even all the way through to the apex, it's not necessary. The only way and only reason you're going to need it or get into a problem is if you miss the prostate. Outside the prostate, basically.
Professor Cheng?
Yeah, thanks for the excellent presentation. Seeing is believing, and all very elegantly done. My question is regarding salvage and subsequent treatment. Significant number of patients may need repeat treatment, maybe new lesions or residue in treatment zone or outside. But we have seen Arno having to go back and do a total prostatectomy. Many patients who might end up doing irradiation. How difficult will it be to put spacer into those post-primary IRE or cryo treatment? The place may be scarred up. Meaning that if patients live long enough and require treatment, do we need to worry about what are the subsequent treatment and what will be their quality of life in terms of quality, complications and incontinence? Thank you.
So we've looked at our salvage options in the post-IRE setting. Approximately 50% of people have a biopsy negative on a redo IRE case. And from a technical point of view, it's not particularly difficult. It's a little bit more difficult if you have an infield recurrence, but the infield recurrences are much less common than the outfield recurrences. As far as radical prostatectomy goes, IRE is a little bit unique in that it's got about 30% of them form cystic cavities and about 70% form scar tissue. When you've got a cystic cavity and you're doing a radical prostatectomy, it's sometimes hard to keep out of that cystic cavity. But that's not where you get a positive margin at that point. You don't tend to get tumour there. You tend to get tumour elsewhere in the prostate. So from the point of view of getting a negative margin and continence, it's pretty good, but the potency rate in the salvage setting is not as good.
Great. What about other options? Shelley, have you done any post-laser prostatectomies?
We have. It was a novel finding, part of the trial. We weren't quite sure what to expect. So we went in with some trepidation and we realized that the effect doesn't seem to be beyond the prostate. So it's kind of what you would see in like the MRI scan. The failure rate's always inside. It felt more like an aggressive biopsy or someone who's gone 2 or 3 biopsies. So it is stuck, but the planes are preserved. Posterior adenum is always preserved, so there's no issue in regards to putting spacer and some gold seeds, if you like. And it's to the point now we actually allow our fellows to do part of the operation, so it's not that complex.
Sam?
Well, I think for cryo, I think the posterior plane is quite preserved, but for HIFU, I performed 2 cases of radical prostatectomy. I would say it's usually more stuck, and intraoperatively, I really don't think I could have put in any spacer if the patient was going for urination. And for one case, I even need to do a retrograde dissection in order to get that little bit of rectal adhesion out in the last bit. So I guess it's a bit variable, but it's still doable. Unfortunately, the patient's content seems to be quite satisfactory in the end. So I think it's quite variable in the outcome.
I share a little bit of experience after HIFU with patients' recurrence. It's more stuck actually on the lateral aspect, not so much on the adenovillus. But the other point is that cryo and HIFU, I think, are the more established modalities that's known to treat salvage after radiotherapy failure. And Focal Therapy Society has a consensus paper that is being submitted, right?
Okay, Pin has a response. He's the one who wants everyone to send him the focal failures, right?
So I've actually attempted to place spacers in patients who failed when it's been done elsewhere, because we don't have that many failures. But the reality of it is that it is extremely challenging if you actually had an ablation that you went outside the cap, you go outside the capsule and you freeze outside the capsule. It is almost impossible to get a spacer in. My recommendation is to attempt barigel, but even then it's very tough to do that. And I do think that at the end of the day, in those cases, perhaps consider a salvage modality that doesn't entail spacer or barrigel. It's almost impossible to get it in.
What about prostatectomy? Do you find that, have you done any of those?
Haven't done that many of that, but I've attempted spacer on at least 6 of these patients that have a posterior recurrence,
Okay.
and it's impossible to get in. With barrigel, I've probably got 1 or 2 in, and even then, it's usually, I don't know if it actually helps much. Perhaps, consider doing an MRI linac,
Yeah.
ablation with the SBRT.
Thanks. I've done 3 salvage prostatectomies, but those are all anterior cryoablations, so I haven't had to do one for posterior. For the anterior, they are more stuck at the place where you ablated. I couldn't imagine doing that for the posterior. I'll be very wary.
If you do end up placing spacer on somebody who subsequently changed their mind and you end up doing a prostatectomy, though, it'll be the easiest posterior dissection.
Have you done that?
One of my friends have done it when he sent us the video, and it's like the entire thing is lifted.
Okay, great. But I think that's a really important option because it is a journey. So we have many experienced people in the audience. Has anyone done prostatectomy after posterior zone cryotherapy? No. All right, silence. All right, okay. Let's move on to the next session. Thank you so much to the faculty. All right, let's have the next batch up. You want to announce their names? Yeah, just call them up.
So the first, we have Dr. Peter Chu for peri-uteral tumors using HIFU.
And we can have all the speakers for the segment come up, please.
Dr. Klotz, Dr. Said Sujong.
Should I?
Yeah, take it away, Peter. Thanks so much. Peter is going to show us peri-uteral tumor HIFU. Yeah.
Yeah, so hi everyone, I'm Peter from Hong Kong. So please forgive me, Jack, for not using your case, because your case, you show me a peri-uteral, that's actually an anterior tumor, which is so easily done. So I'm going to show you a most challenging case.
Ken, no problem, Peter. Thanks so much.
And also that case has so many calcifications, and you're asking us to do HIFU and then TOSA. So that's not fair. So I'm going to show you another case. And also wish to ask Professor Klotz's opinion on my case too. So it's a 70-year-old diabetic patient on pacemaker, okay? A patient on pacemaker. And the first thing is that even MRI is more challenging. Right, so PSA 4.7. It's a tiny prostate, untreated prostate, 60 mil, just 3 months ago. So 7 millimeters Pyrus 4 lesion, mid-gland peri-uteral at the lower half of the urethra. So it's not that, this is a 60 mil prostate, which is very magnified. And the lesion is at the central. When I first looked at the T2, I thought it's nothing. But when I look at the DW and the ADC, I thought it's something. And then, but unfortunately, I did not do the biopsy myself. Someone actually sent this case to me. And the midline urethral lesion was 3+4. And unfortunately, there was also a bit of 3+3 of the left mid and left posterior sector. And then I was thinking, and that man was referred to me because for HIFU. And he would not agree to any radical treatment at that point. So I decided to HIFU. So just to show you also the sagittal view, it is more of the mid-gland, mid-apical, not really apical. So in this axial view, it's the pink area is the MI lesion. The light blue area is not the MI lesion, but I just wish to remind myself that I need to cover that area too, because there is some systematic biopsies, 3+3 over there, which he wished me to ablate that too. So I used a HIFU. I only have sonoblade, and I planned this for 3 zones, 4, 3, and 3 centimeters, of course, from the beginning. And this was the first zone. I put in a Foley's catheter to make sure I know where's the urethra for this case. And therefore, with the Foley's catheter, I did not treat really the midline anterior, but of course, the tumor is not there too. This is the second zone. Still, the Foley's catheter is there, and I treat right next to that. And you can see in the 3 different planes what is the coverage. So I covered quite a pretty large area for this 70-year-old man. And most of the time, I get excellent or large changes on the HIFU upon the on the sonoplate machine. And the third zone would be the zone which is most important because that's actually the tumor zone, which I take away the Foley's catheter and ablate. And fortunately, the whole, along the way, it's excellent reactions along. So, and I use a drop technique to cover the apical and the more lateral regions. I need to make sure that I cover the margins well because it's a tiny prostate, 16 mil prostate. So HIFU time was 46 minutes because it's a very small prostate, sparing the anterior part, the right lateral and right posterolateral part. I deliberately put a Foley for longer time because it was, really circumferential or the urethral treatment, but only sparing the anterior part. So fortunately, he could void on day 10, which was the first attempt. And this was the day 20 MRI prostate, T1 with contrast. And it shows that a good coverage. Now you can argue that I'm probably doing a subtotal ablation of this thing. I think it is because the reaction was actually exceptionally well, so it actually is slightly more than that. It's not day 10, but day 20. You know why? Because when I sent the patient to the MRI, they rejected me because they have a pacemaker. And then they say they need a cardiologist to adjust it before that. And they need a cardiologist, because for that, his condition, they said they need a cardiologist to be standby before, during the MRI, after interrogation. Anyway, the PSA dropped by 88% at 3 months. And the Uroflow was Qmax for 27. And it was, and I did a Uroflow because I was fearing if there will be any urethral stricture for that case. So, yeah, maybe you can discuss further on. Yeah.
Sounds great. Thanks, Peter. Beautiful case. Very nice cavity there, and you got his catheter off, so that's fantastic. All right, let's go to the next one, which is Dr. Lawrence Klotz himself, peripheral tumors, Tulsa. Let's have Dr. Klotz's slides on, please.
Yeah, so I'm presenting a different case, which is a local recurrence after a patient who had a radical prostatectomy and subsequent salvage radiation. I won't dwell on the Tulsa. There's very limited data on salvage Tulsa, but it looks really promising. This is the one publication from Finland, 11 patients. Now they've updated that with 41 patients, with about 90% of patients having disease eradication. But this is a case of a patient who happened to be a medical historian, had surgery about 5 years ago, grade group 3, positive margin, had a biochemical recurrence and was treated with salvage radiation about 2 years later, and now again has a recurrence. So you can see this is his MRI showing a periurethral recurrence, again, post-radical prostatectomy and salvage radiation. So, I mean, there's really not many options for a patient like this, and we elected to treat him. He was very interested in having this eradicated. His PSMA scan showed no other disease other than the local disease. So you can see in the two planes, this is the treatment planning with Tulsa. And this actually shows the treatment. This is speeded up quite a bit, but you can see basically the target was limited to around 1 centimeter around the urethral applicator, pretty much from base to apex, a total of 8 segments. And this was remarkably smooth. Tulsa does involve periurethral cooling. There's some cooling irrigation through the applicator, which protects 1 to 2 millimeters of periurethral tissue. There are ways to treat that 1 to 2 millimeters, which we invoked in this case, which was to avoid the cooling. At the end of the procedure, the heat kind of diffuses backwards towards the applicator. And then at the end, the post-gadolinium essentially showed no perfusion in the treated area. So this was a little audacious. It's the first time, as far as I know, anyone has tried to do this. And he's had now undetectable PSA. His PSA was about 2 prior to the procedure. It's remained undetectable. He has incontinence. It's not surprising given all the treatment he's had. And his last MRI showed no evidence of recurrence. So I think, there are not a lot of options for this scenario. Tulsa is clearly one of them. I should also say, I think both the anterior and the posterior cases we've heard about today, Tulsa would be an effective option.
Thank you so much, Dr. Klotz. And thanks for showing that very nice case, very pertinent. I have a patient that was just like that. I didn't know what to do. Let's save that discussion for later on. Next, we have Dr. Saiduzaman, who is going to show us a case on IRE. Dr. Said is a fellow with SGH Urology, and he's actually showing one of my cases where we did IRE for a peri-retro tumor, which is why I started IRE. So it would be great to have everyone's comments. Let's have his slides up, please. All right, let's go.
Describe the procedure of IRE treatment for prostate cancer. This was the summary of the patient we have treated. This was our treatment flowchart in the operation theater. This was our operation theater setup. Ultrasound monitor and IRE monitor on the left side of the patient, and flexible cystoscope monitor was the right side of the patient. We used angiodynamic nanoknife system for this treatment. This procedure was done in extended lithotomy position under general anesthesia with deep muscle paralysis. First, prostate was imaged by TRAS ultrasound with a stapler and localization of the lesion. Then planned for needle placement at least 1 centimeter apart from one and another. We used brachytherapy grid for precise needle placement. This was our final needle positions. Initially, 10 test pulses were administered to evaluate the ablation graph and review each electrode pair to ensure the goal of 30 amperes and electric voltage goal was 3000 volt. Then the ablation pulses were administered with 80 pulses and the graphs were evaluated. Here we can see the ultrasound image showing the artifacts in the ablation area due to electrophoretic gas generated by high voltage electric current. When the treatment is completed, all needles are taken out. Flexible cystoscopy was performed before and after the IRE treatment to ensure that the urethra is not involved by the needle. Then perineal compression was applied for at least 5 minutes and a 16 French Foley catheterization was done. Our operative time was 40 minutes. Patient was discharged with Foley catheter on the same day, and Foley catheter was removed on postoperative day 3. Thank you very much.
Thanks so much, Said. Very good, very nice video. Next, let's have Dr. Sanjit Gai. Peri-urethral tumors, how would you do it inboard? Take it away, sir.
Thank you, thank you, Jack. I just have a couple of slides. Dr. Klotz has already spoken about TULSA, and there are 2 further in-bore kind of devices for treating for focal therapy of prostate cancer. So I'm going to show an example of MR-guided HIFU, transrectal HIFU. So this is the Insight Tech device, and then in-bore laser ablation using the diode laser as well. So this was a 69-year-old gentleman, grade group 2 disease. You can see a very large tumor in the anterior transition zone. And he was consented for, in our MR-guided focused ultrasound transrectal kind of trial. And this is his appearance on the left-hand side immediately after treatment. So, we did go for wide margins, about 10 millimeters. The advantage of in-bore is you get that instant thermal feedback. If you see that the temperature that you wanted to attain is not obtained, you can increase the amount of energy that you're depositing and then get that temperature feedback. So on the post-contrast images, you can see, you probably appreciate the kind of small amount of enhancement in the urethra itself, but we did ablate the entire urethra. And because we were treating from the transrectally, we did not place a Foley catheter during the treatment. We did place a suprapubic catheter on the morning of. I generally place a Foley catheter immediately after the treatment just to keep the urethra open. Otherwise, you're worried about the stricture. We kept the Foley catheter in for about 10 days, 8 or 9 days. And then the Foley catheter was removed. There was no blood or neck stricture. We were worried a little bit at the end of the treatment, but he remains totally asymptomatic. On the right-hand side, you have his image from 2022, which was 5 years after his treatment, and he remains completely asymptomatic. His PSA now is 0.45. If we go to the next slide, this is an example of in-bore focal laser ablation. You can appreciate tumor in the right transition zone. Again, a fairly sized tumor. And my thought is, if you're calling these PARAS 4 lesions, that means they're not very aggressive, right? Like they don't extend into the peripheral zone. So the idea always is that you want to kind of, ablate as much of the zone in which the tumor is present. You can see the ADC map there showing some restricted diffusion. We placed about 4 or 5. You can appreciate the location of 3 catheters on this particular image. And again, post-contrast image at the end of the procedure kind of shows the area that we ablated. He has not reached his 1-year mark as yet, but we left the Foley catheter in. Now, because this is an interstitial form of treatment, I usually leave a Foley catheter for the treatment itself. He did not have a suprapubic catheter, and his catheter was removed on day 6 or day 7, and he did not have any difficulty in voiding. Thank you.
Fantastic. Thanks so much, Sanjit. Very, very nice case again. Great. So I think we're now open for comments.
Yeah, so I have a question for Peter. I was just wondering for peri-urethral tumor, if you use HIFU, do you follow them up a bit differently in terms of the functional outcomes? Do you scope them to see how's the urethra? And how do patients generally feel? Do they have a lot more urethral sloughing, dysuria?
To declare, I actually only done a couple of these cases, and fortunately they did well. I did not do routine cystoscopy, but I was planning to do that if the flow, the uroflow has any issues. Sloughing wise, I was fortunate that after Foley removal, there was really no symptom. I mean, no bothersome symptoms to that. So, I read about previous whole gland HIFU, whole gland cryo patients. They do have quite a lot of sloughing, which can last for 4 or 6 weeks or even more, which is quite disastrous to the surgeon too. But maybe I was fortunate. But I actually spared the anterior 1/3. I guess that's maybe the reason why it got away, for that case. Yeah. What's your opinion, Professor Klotz? Do you think we should do the HIFU for that? Or?
Yeah, I mean, if you treat the urethra with HIFU, you get more toxicity, but still manageable, tolerable levels, I think. So a periurethral tumor, you're going to get periurethral effects. Yeah. The urethra is going to be treated. Yeah. You can't avoid that. Otherwise, you end up sparing tumors. So I think I've done quite a few. I started out doing whole gland HIFU for 6 or 7 years, and it's pretty reasonable treatment, except you do get essentially you get fusion of the lateral lobes as they cool, because they're semi-liquefied, and you get intraprostatic strictures. In my personal experience, in fact, in our group, it was about 25% of cases. So we abandoned that and pretty much use HIFU only for up to hemiablation now. But you could do it.
Then on the other hand, would it be if we plan for at most hemiablation, in fact, we should go closer to the urethra to get the most margin that we can, because in fact, if it's hemiablation, not whole gland, the risk of strictures, intraprostatic strictures, are not that high.
Yeah, I think you can, when you do hemiablation, or when I do it, you can treat right up to you can treat half the urethra, and it doesn't seem to be a problem. again, it's that bilateral therapy and the resulting kind of fusion of the tissue in the midline that causes the problem, in my opinion.
Dr. Klatz, in your experience, when did those strictures occur? Like, what was the time frame after treatment?
Usually within the first, 3 to 4 months. And that came as a complete surprise. Like, we were early adopters of HIFU. I'm talking about my group in Toronto. And it was sold as, no patients have any problems. And I thought, initially I started seeing these patients, I thought, what am I doing wrong? And it turned out all of us were having the same problem. So, I mean, it's a real limitation, I would say, of whole gland HIFU.
And I think that does lend some important lessons to those more circumferential tumors, because what you're saying is that there's perhaps a sweet spot where if you leave enough percentage of the circumference untreated, things are going to be okay. Where do you think that is? I mean, just ballpark. Like what percentage of the segment of the urethra being treated would be okay?
Half.
All right, thanks.
Just to add that, like while we do cryo, we put in the urethral warmer. The first thing is I wish to seek. I'm just an early user of cryo. I want to ask how much can we stop the warm water from running, or like how slow should we stop it, or actually we should take it away? For the experts, I want an answer.
Okay, we should poll the audience. Because
do not stop the flow. Okay, you can turn off the warmer, but do never turn off the flow. It will freeze solid so quickly. So, do not do it.
How about turning down the rate?
It's not the rate. You just turn off the heat. You have to make sure your bag's not too big because you need the temperature change of your warmer.
Turn off the heat. Okay.
Anyway, it gives about a 3 millimeter margin around that warming catheter. Yeah. You can turn off the heat. You feel the bag. You feel it getting colder. You watch your ice change. And I think, I don't want to give you a number, but definitely not more than 4 or 5 minutes. And you have to be really careful. And you notice that it starts getting really cold. You're like, okay, I think we're good. We saw the ice cover the area, and then you've adequately treated it. But it's a little bit jarring, and no one recommends doing it, but we do it all the time to make sure we cover those peri-urethral tumors in the prostate.
Okay, that's great advice. So people have told me before, clamp the warmer. That means they've actually never done it, right? It just sounds like an idea.
No, you gotta turn off the warmer, but you don't stop the flow. And one of my partners, Jim Weissau, he will go to bed and he would do that after the freeze has actually been done. He'll turn the warmer itself off, and then you'll see that the flow going into the urethral warming catheter actually slows down. And at some point, you should probably turn it back on. When that point is, nobody really knows.
Push that ice a little further. It's not at the beginning. You've gotten your treatment, you've gotten your margins, and then you turn that off.
Right. Right, not at the beginning. Once the freeze has actually been done, then you turn it off and you watch the ice go close to it.
All right, man. Thanks for sharing. Sam,
just a follow-up question, because in fact we are trying to see how can maximize the use of cryo, and from our kind of understanding, if the ablation is within the prostate but not near the apex, even if there is some so-called complication within the apex, it still can be managed endoscopically, because just like you're doing transurethral resection, it's still all right. So is there a big worry if we really take off the warmer when we're dealing mainly within the prostate lesion?
You can't do cryo next to peri-urethral. That is not the case, I believe, in any way, shape, or form. So inside the prostate, I've never had an issue with freezing, quote unquote, the prostatic urethra, which is basically the lateral lobes as they come across.
Right.
You don't want to, and like, let's be honest, we all do focal therapy. There's a lot of the sphincter you can damage and still not have an incontinent patient. So, there's some margin for error, because if it was, we would have much more higher incontinence rates, because we all treat apex tumors, but you should be able to visualize where you are. And as long as you don't treat the sphincter, I think you'll be in a good place. I've never had an issue. Anyone else disagree? How much sphincter have you?
I don't know.
burned?
I treat a fair number of anterior and apical stuff and near the urethra because for a long time cryo was the only thing I had. But I do find that when I do the MR 1 year later, there is a sliver of viable tissue there, even though I froze really hard and I think the eyes joined above the urethra. Yeah. But just that I think Tom's not here, he stepped out. But because I learned cryo from him and he said don't ever do anything to the warmer, I've never done anything to the warmer. So I've always left it on. Yeah.
What's Laurie saying?
Well, I think if you, there is a risk treating apical tumors of urethral sphincter damage that's associated with a higher rate of incontinence.
I don't disagree, but the question is how much of the sphincter can be damaged? Because
not too much.
All right, guys, this is a great session. Dinner is at 7, so we'll see you at the dinner. Right now, they need to roll out these tables and roll in the round table, so we're going to have to clear out the room. So just another round of applause for everybody. Thanks so much.